Welcome to the new section on adrenal insufficiency. In this particular section, we'll be discussing in detail about the etiology, pathophysiology, clinical features, workup, and the management of adrenal insufficiency with special preference to the salt-wasting adrenal crisis, which is a medical emergency. So without wasting much time, let us start with the basics of adrenal insufficiency, which is very important for understanding the etiological principles of adrenal insufficiency. For that matters, people who have not watched the previous video, I'm going to start with the hypothalamic pituitary adrenal axis. Hypothalamus is going to control the pituitary gland, especially the anti-pituitary. With this chapter's regards, it's going to control the corticotrophs through two important hormones and factors. One is the CRH, otherwise called as corticotropin releasing factor, is going to act on the CRH receptor to release more ACTH, and the second control comes from the antidiuretic hormone, that is vasopressin, which is going to work on the V1B receptors to stimulate the release of ACTH. We all know that ACTH is produced in the form of pre-opium melanocortin first, which will be subsequently cleaved by an enzyme called proconvertase to release melanocyte stimulating hormone, ACTH, and endorphins, especially the beta endorphin. So alpha, beta, and gamma MSH, which is produced from POMC by cleavage by proconvertase enzyme, is going to act on the mineralocortin 4 receptor, where it helps in creating anorexia, reduced food intake. And why that point is important? Because there is a separate disorder which we are going to discuss called proconvertase deficiency, where the patient will have reduced amounts of ACTH production because of the poor cleavage from POMC. And it's a condition which is not only going to result in ACTH deficiency, it's also going to result in obesity because of hyperphagia, and that is because of low MSH production. And at the same time, this proconvertase enzyme is also important for cleaving this proinsulin to insulin. So because of that reason, proconvertase deficiency will also result in insulin deficiency, but because of the same, you're going to result in diabetes mellitus as well. So when you have a constellation of central ACTH deficiency with diabetes mellitus and obesity, you think about this proconvertase deficiency in exams. So ACTH is going to work on the mineralocortin 2 receptor in the adrenal cortex, which is going to stimulate the release of cortisol and DHEAs, which is going to be discussed subsequently. And endorphins are going to work on the endorphin receptors, which is important for the pain controlling pathway. We know that this POMC, that is in the form of ACTH that is circulating in the blood, is going to act on the adrenal cortex. And in the adrenal cortex, we have a very important receptor called mineralocortin 2 receptor, which is going to be the reason for the effects of ACTH. Obviously, we can safely write that this ACTH stimulation of zona fasciculata will result in cortisol production. ACTH stimulation of zona reticularis will result in adrenal androgen production like DHEAs and a slight amount of androstenedione. But we have to know the fact that aldosterone production from the zona glomerulosa is almost entirely under the control of renin-angiotensin axis, and it is not under the control of ACTH. We also know the fact that this cortisol is the most important feedback agent for the hypothalamus for CRH release and also for the pituitary for ACTH release. So which means you have a high cortisol, you're going to result in low ACTH and CRH production. If you are going to have a low cortisol, you're going to result in high ACTH and CRH production. Etiologies of adrenal insufficiency can be divided into three. One is the central adrenal insufficiency, that is also called as secondary adrenal insufficiency, and adrenal problem, that is primary adrenal insufficiency. And you can have even receptor defects which might have a mixed features of both central and peripheral adrenal insufficiency. First, let us discuss about the central adrenal insufficiency. First, let us discuss the features of all this. Central adrenal insufficiency will be usually due to some problem in the pituitary gland or the hypothalamus, but problems in the pituitary is quite more common compared to the hypothalamus. Usually, these patients will have low ACTH production, but remember, they might have pan-hypopituitarism or multiple pituitary hormone deficiencies also, but you have to be very careful in this regards. Whenever you have a low ACTH production, it is very difficult to have hyperpigmentation, which means these patients will not have hyperpigmentation, and that's a very seriously important point. And at the same time, because of the low ACTH, the patients will have low cortisol and probably low DHAS, which is not important right now, but the patients will have no salt wasting and a normal potassium because of the intact renin-angiotensin aldosterone axis, which is going to control the zona glomerulosa. So even in the presence of ACTH deficiency, your aldosterone production is unaffected because the control for aldosterone synthesis is something different. So there will be no salt wasting and a normal serum potassium, which means there will be no hyperkalemia because aldosterone is normal. At the same time, as I told you, whenever you have a central adrenal insufficiency, there might be associated multiple pituitary hormone deficiencies. There might be other hormone defects as well, so you have to be evaluating these patients very carefully. So what will happen if the patient is having a receptor level issue? Receptor level issue. There are multiple etiologies, but I'm going to tell only the mechanisms of what will be the biochemical picture with regards to receptor defects causing adrenal insufficiency. Here the MC2 receptor or its associated protein called MRAP, that's melanocortin 2 receptor associated protein. So if any of these things are defective, you might result in poor translation of ACTH action, which means there will be a low cortisol and DHAS. Once again, the aldosterone effects will be unimpaired because of the intact renin-angiotensin axis. So there will be low cortisol, but since the patient is having low cortisol, it's not a central problem. The pituitary and hypothalamus are functioning normally here. So there will be excessive production of ACTH, which is a secondary response to low cortisol. So this excessive ACTH can result in hyperpigmentation because MSH is also going to be in excess. So they can result in hyperpigmentation in these patients. And at the same time, the patients will not have any salt wasting as well because as I told you, the aldosterone will be normally produced and will be normally acting. So there will be no salt wasting and there will be no hyperkalemia, which means they will be having a normal serum potassium. So these are some of the important features of receptor level defects. But what will be the problems in adrenal level defects? Adrenal level defects. There are multiple causes for adrenal problems causing adrenal insufficiency. This adrenal issues causing adrenal insufficiency is what we refer to as a primary adrenal insufficiency or otherwise referred to as a Addison's disease. So what will be the biochemical picture here? Obviously the patients will have low serum cortisol and this low serum cortisol obviously is going to stimulate the pituitary and hypothalamus here, which is normal. So they're going to increase the ACTH production. As I told you already, like how you have a log linear relationship between T4 and TSH, you also have a log linear relationship between ACTH and cortisol. So decline in cortisol will be resulting in increased production of ACTH and POMC. Because of the increased ACTH production, obviously these patients also will exhibit hyperpigmentation. But because it's an adrenal level problem, it's not going to affect only the cortisol and DHAs, it's also going to affect the aldosterone production also because it's an adrenal level problem. So these patients will usually have salt wasting. At the same time, they will have hyperkalemia because of the aldosterone deficiency. So what are the types of adrenal insufficiency that has hyperpigmentation? Usually peripheral defects like receptor defects or actual adrenal problems. What are the types of adrenal insufficiency with salt wasting? Only the peripheral problem, especially the adrenal issues only will have salt wasting. Receptor level defects and central adrenal insufficiency will not be usually having salt wasting and hyperkalemia. Now, after knowing the biochemical picture, let us see the etiologies one by one. First is the pituitary central etiology. You have a whole lot of etiologies based on this pituitary lesions itself. Let me tell you the most important ones first. First one is the infiltrative lesions. Infiltrative lesions are well known to cause postpituitary lesions, but anterpituitary lesions and ACTH deficiency can happen in certain infiltrative lesions with special preference to lymphocytic hypophysitis. That's a very important one, lymphocytic hypophysitis. If you remember lymphocytic hypophysitis, which I have explained in the basics of pituitary video itself, where I have told it is very common in patients who are pregnant and it's common in patients who are using this cancer immunotherapy agents like ipilimumab, which is an anti-CTLA4 antibody. So where this is a lymphocytic infiltration of the pituitary stalk and probably the anterior pituitary, which will usually result in ACTH deficiency, very commonly followed by TSH deficiency. Clear? And it can mimic a cellular mass. It can mimic a mass lesion or a stalk lesion in the pituitary area. So you have to be careful about this. Lymphocytic hypophysetis. Or you can also have Langerhans histiocytosis, which is very commonly a disease of children. It can be due to other infiltrative lesions like sarcoidosis, but pretty rarely. Remember, whenever you have an infiltrative disorder causing any pituitary hormone defect, usually there will be a thick stalk in MRI, which will be very easily identifiable most of the times. There will be a thick stalk here. Apart from infiltrative lesions, we have radiotherapy, which can affect the pituitary, but very importantly, you have to know the fact that radiotherapy is going to affect more of hypothalamus compared to that of the pituitary. This fact I have told you and substantiated many times in the past, that hypothalamus is more sensitive to radiation compared to that of the pituitary gland. So whatever doses I am trying to tell here is going to first affect the hypothalamic hormones. Obviously, if you affect the hypothalamic hormones, you are going to affect the pituitary release of hormones as well. So radiotherapy wise, we have to know the doses at which you will result in deficiency of hormones. At less than 12 guys, there will be no effect either on the hypothalamus or on the pituitary gland. Beyond 12 guys, the first hormone to be affected will be the growth hormone releasing hormone from the hypothalamus, which is going to affect the growth hormone release. So this is the first hormone to be affected and reduced and will be deficient with regards to radiotherapy. And please do remember, at 18 to 24 guys, you will have growth hormone deficiency, but along with that, you will have one important clinical problem, that is excessive gonadotropin release due to increased GnRH, resulting in precocious puberty, especially in children. There will be increased gonadotropin production rather than reduced gonadotropin production at a dose of 18 to 24 guy. Beyond 24 guy, there will be ACTH deficiency because of CRS deficiency of the hypothalamus. At beyond 30 guys, you will result in gonadotropin and TSH deficiency, which means gonadotropins and TSH are relatively more resistant to radiation compared to that of other hormones. Please do understand the fact, I am substantiating one more time, 18 to 24 guys, it's more gonadotropins, precocious puberty in children, and beyond 30 guys, it will result in gonadotropin deficiency and delayed puberty rather than gonadotropin excess. This is a very important point for exams. Apart from this radiotherapy and radiation related effect, we also can damage the pituitary through surgery, like a transfemoral surgery where you can have panhypopituitarism after the transfemoral surgery, or it can result as a problem of apoplexy. We know what apoplexy means. Usually it is due to a macroadenoma screwing up its own blood supply and bleeding into the area, causing sudden mass lesion, resulting in headache, visual field defects like bitemporal myopia, and it's an endocrine emergency where it will be acute in presentation. And we have another disorder that's called infarction. The best example for pituitary infarction and vascular insult is Sheehan syndrome, that's called a postpartum pituitary necrosis due to postpartum hemorrhage resulting in hypotension and shock. Sheehan syndrome will be usually subacute in their presentation, and it will be more presenting as lactational failure rather than other hormone deficiency, because the first manifestation of Sheehan syndrome is lactational failure. We have seen that already. But which are the areas that are prone for vascular insult and related damage in the pituitary? So this is the posterior pituitary. So where I can write AVP is the most important here, and anterior pituitary here, where I can split the anterior pituitary into three zones: the anterolateral zone, the central zone, and the anteromedial zone. So this is the anterolateral zone, which I'm going to shade in red. The anterolateral zone will be usually contain cells that produce growth hormone and probably prolactin. And we have a central zone which contains cells that are going to produce ACTH and TSH. That is the corticotrophs and the thyrotrophs. And the medial area, relatively medial area, which is going to produce the gonadotropins, where they will be having the gonadotrophs, which is going to synthesize FSH and LH. So which are the areas that are sensitive to vascular insult? The growth hormone and the TSH. Obviously the prolactin also will come in that, especially with regards to the postpartum patient. The prolactin is very, very sensitive compared to all the other hormones. Even in postpartum necrosis, the first hormone to become deficient is growth hormone only, and after that only your prolactin will become deficient, which means growth hormone is exquisitely sensitive to both radiation as well as vascular insult. So that will be very sensitive to vascular insult, or otherwise I can call it as ischemia and infarction. whereas ACTH and gonadotropins will be relatively resistant to vascular insult. Resistant to vascular insult. Clear? So this is a very clear-cut important point where in a postpartum necrosis, the patient will coming with lactation failure due to prolactin deficiency. At the same time, they'll be having growth hormone deficiency and TSH deficiency as well, resulting in central hypothyroid states. Apart from that, we have a whole lot of genetic causes, which I gave an overview already in the basics of the pituitary. Now let us see the genetic causes in detail. To understand the genetic causes that causes hypopituitarism, we have to know the development of the pituitary. So this is the very simple image that will tell you the development of the pituitary, where initially it starts from the oropharynx and the neurolectodome. Initially the oropharynx will become Rathke's pouch at around 3 to 5 weeks of time, 5 weeks of age, and neurolectodome will be forming the posterior pituitary or the neurohypophysis. Slowly both will fuse together, resulting in adenohypophysis and neurohypophysis, as we see as a mature pituitary gland. First, initially we have an early embryonic period, then a period of cellular differentiation, then we have a period of formation of mature gland. So at all these steps, you have some important genes and transcription factors which play a very vital role in the development of the pituitary. For example, in the very early embryonic period, we have certain genes like WNT5, FGF8, then we have bone morphogenic protein 2, BMP2 and SHH. These are some of the genes that are very, very important for early development of the Rathke's pouch and the neurolectodome, which is going to form the future pituitary. Apart from that, there are some other transcription factors which are also very important for the early embryonic development, like SOX3 and HESX1. Especially this HESX1 is really important because defects of HESX1 can result in disorders like septo-optic dysplasia, which you have discussed already, and it can also result in craniofacial abnormalities. So that's the very important point here. And then they become cellular differentiation. But apart from that, there is some genes and transcription factors that has an overlap with cellular differentiation and early embryonic life, early embryonic development. Let me tell you what are the genes that are responsible. Like we have LHX 3 and 4, and we also have PTEX 1 and 2. LHX 3 and 4 and PTEX 1 and 2. So these are the genes that are important for the early embryonic development as well as for the cellular differentiation. For further cellular differentiation to form a mature gland, for further cellular differentiation to form a mature gland, you need certain transcription factors which are really, really important. Like for example, for the formation of all the cells in the pituitary. So I can write, we have cells that produce ACTH, we have cells that produce growth hormone, we have cells that produce prolactin, we have cells that produce TSH, we also have cells that produce gonadotropins. For all these things, a very important transcription factor called PROP1 is necessary, because we have some PROP1 defects which we'll be discussing in some time. So then we have one important transcription factor called GATA2, which is very important for the TSH and the gonadotropin production. This GATA2 is a transcription factor that is very important for TSH and gonadotropin production. And finally, we have another two important factors, that is SF1, that is steroidogenic factor 1, which I have studied already in the DSDs. And DAX1, again, we have studied in the DSDs. So these two are very important for the gonadotropin production as well. All right. And there are some other factors that are also important for individual cell differentiation. Like for example, ACTH differentiation, you need POMC, that is pre-opiomelanocortin, to be produced by certain cells. And we need this LAF. We also need a factor called neuro-D1, otherwise referred to as ND1. And we have another transcription factor called TPIT. All of these things in unison will result in the development of the corticotrophs and production of ACTH. And similarly, for the production of TSH, we need a very important factor called TSH beta, so which will be important for producing the beta chain of the TSH. Similarly, alpha subunit of TSH is common for TSH LH, FSH as well as the beta HCG. So for that production you have another transcription factor like GATA2, which is very important for production of TSH and gonadotropin, because GATA2 will induce the production of the alpha subunit, which is going to be common for TSH, FSH as well as LH, which are nothing but the gonadotropins. So after knowing all these things, it's now time to understand the defects. So what are the defects you're going to result in? You can result in HESX1 defects. HESX1 defects will usually result in multiple pituitary hormone deficiencies, because SX1 result in pituitary agenesis sometimes or hypoplasia sometimes. So it might result in multiple pituitary hormone deficiencies. At the same time, it can result in optic nerve hypoplasia. That's a very important point. Remember, same SX1 defects can also result in production of that septo-optic dysplasia, which I already discussed in the basics of the pituitary, where there will be absent central structures like corpus callosum, your septum pellucidum, and probably optic nerve hypoplasia and even pituitary agenesis. So all these things can be associated with septo-optic dysplasia, which is also usually due to this SX1 defects only. So I can write SX1 defects will result in multiple pituitary hormone deficiency and optic nerve hypoplasia. Along with that, a syndromic feature called de Morse's disease, that is called septo-optic dysplasia. Then problems with SOX3 will result in multiple pituitary hormone deficiencies. At the same time, they'll also be resulting in hearing loss and probably anophthalmos, because it's important for special senses like vision and hearing. Anophthalmos. Then problems with PTEX1 and 2. This is important for early embryogenesis as well as the cellular differentiation stage, and even after birth in the neonatal period also this PTEX1 is very, very important for continued growth of the pituitary. So PTEX1 and 2 defects will result in TSH, FSH, ACTH and prolactin deficiencies and will be associated with sensory neural hearing loss. LHX4 deficiency will usually result in deficiencies of growth hormone, TSH and ACTH, and there will be a absent pituitary stalk. That is the clue here. So whenever you have an absent pituitary stalk, along with that, if you have ACTH deficiency and other hormone deficiency, think about LHX4 defect. PROP1 defects, we know very well. PROP1 defects will result in all pituitary hormone deficiencies, because PROP1 is a very important transcription factor that's important for all the cell lineage development. So it will result in growth hormone, prolactin, ACTH, gonadotropins like FSH, LH and TSH defects. And at the same time, this is one condition where you might have a MRA picture of an enlarged pituitary, which can mimic a pituitary tumor. Especially this is due to enlargement of the intermediate lobe of the pituitary, because in the anatomy and the pituitary basics I have taught you about the intermediate lobe of the pituitary, which is between the anterior and the posterior pituitary, which can enlarge in patients who are having PROP1 defects. That will result in mass lesion like effect on the MRI. But remember, over time this enlargement will be subsequently replaced with atrophy of the pituitary gland. But initially at birth at least they might have enlargement of the pituitary gland. And you might have this TPIT defect. TPIT is very important for ACTH production. So they will be having ACTH deficiency where there will be morphologically normal pituitary. And POMC defects will result in ACTH deficiency, and at the same time POMC is important for production of other things like melanocyte stimulating hormone as well as your endorphins. So because of the same reason, they might result in depigmented hair, because you cannot produce this melanocyte stimulating hormone, which should act on the MC4 receptor on the melanocytes to produce pigmentation. So you might result in depigmented hair in this scenario, because POMC is the precursor for formation of both ACTH as well as MSH. And you can have this proconvertase 1 deficiency, where I told you proconvertase is important for cleavage of POMC as well as insulin. So that is the reason why they will be resulting in isolated ACTH deficiency. At the same time, other markers like patient will be obese because of reduced MSH acting on the MC4 receptor, which will result in abolition of this anorexogenic pathway and more activation of orexogenic pathway, resulting in more eating of food and obesity. And the patient will also result in diabetes mellitus because of poor insulin production, because you have pre-pro insulin. This pre-pro insulin will be cleaved by a proteolytic step to pro-insulin. this proinsulin has to be further cleaved by this pro-convertase 1 enzyme to a mature regular insulin molecule, which has two chains. One is A chain and the B chain of total 51 amino acids, right? But remember, whenever you have a pro-convertase deficiency, you will not be able to produce mature insulin and you will be ending up with only production of proinsulin. This proinsulin has approximately only 5% activity of insulin on the insulin receptor. That is a receptor tyrosine kinase. So that is the reason why these patients may suffer from insulin deficiency resulting in diabetes mellitus as well. So I've told you a lot of genetic defects which can result in problems in the pituitary and ACTH deficiency causing central adrenal insufficiency. At the same time, these are also some of the important genetic causes for pituitary insufficiency and hypopituitarism. Apart from that, there could be certain anatomical causes that can cause pituitary insufficiency and central adrenal insufficiency, like for example, holoprosencephaly. This is the most important. Holoprosencephaly. The most important genetic defect in holoprosencephaly is SHH, because these genes are not only important for pituitary development, this is also important for the craniofacial development. So that is the reason they will be resulting in holoprosencephaly. One of the hallmarks of holoprosencephaly is additional presence of blindness and nystagmus. The patients will be having both blindness as well as nystagmus, so which is often referred to as a roving eye sign, which is very important in pediatrics to find out many disorders, including this holoprosencephaly. At the same time, they might be having endocrine problems, especially the pituitary defects, like they might have diabetes insipidus. Along with that, they might have ectopic posterior pituitary, where the fusion of the anterior and posterior pituitary is actually mediated by one of the important factors like SHH. So defect in that will result in ectopic posterior pituitary and diabetes insipidus. Apart from that, growth hormone deficiency, TH deficiency, as well as ACTH deficiency can result in patients who are suffering from holoprosencephaly. So I've told you about the genetic defects and the cause of central hypopituitarism and central adrenal insufficiency in detail. So any of these things could be a question, but I do expect this pro-convertase 1 defect, which is the most important, probably TPIT defects, which are also very important for exams. Apart from that, remaining just for a knowledge, and if you want to know for exams, you can write it down. We have this receptor level defects, because receptor level defects are also increasingly recognized nowadays as a cause of adrenal insufficiency. So we know how a receptor level defect will be there. It will mimic adrenal insufficiency, Addison disease, but they will not be having a salt wasting, because it's a MC2 receptor defect. So whenever you have a MC2 receptor defect, the adrenal cortex will not respond to ACTH, which will result in cortisol deficiency, maybe having a DHEAS deficiency, but aldosterone production will be normal because it's largely mediated by renin-angiotensin axis. So MC2 receptor defects will result in familial glucocorticoid deficiency type 1. Similarly, we have a protein called MRAP, that's called mineralocortin 2 receptor associated protein, that's ACTH receptor associated protein, which is also needed for proper functioning of MC2 receptor. If there is a defect in MRAP, that will result in a type of cortisol deficiency called familial glucocorticoid deficiency type 2. And third type of defect, which you have seen already, is called AAA syndrome, otherwise referred to as Algrew syndrome, where we know where is the defect. It's the problem in AAAS gene on the chromosome number 12. So whenever AAAS gene is affected, so this is going to produce an important protein called WT, repeat regulatory protein. That's called WT repeat regulatory protein, and this will be defective. Because of the defect in this protein, it will result in a constellation of features called Aladin, where Aladin is an acronym that's going to stand for alacrimia, achalasia, adrenal insufficiency, and you know this adrenal insufficiency is due to ACTH resistance and not due to ACTH deficiency. That's a multiple times asked question, because here the problem is the receptor. So they will be having ACTH resistance. And finally, N stands for neurological abnormalities, especially the peripheral neuropathy. And we are moving on to adrenal causes per se, which are the most common cause of adrenal insufficiency in the world. Adrenal causes per se can be divided into pediatric and childhood causes and adult causes. Pediatric, only one cause you have to know, even though the list is exhaustive, that is 20-hydroxylase deficiency, which is going to be the most common. And adults, only one cause you have to remember, that is tuberculosis in India. That's TB is the most common cause of primary adrenal insufficiency in India. Western world, you can probably think about autoimmune adrenalitis, where TB is very, very less prevalent there. But in India, it's always TB, and that's very, very relevant for your clinical practice as well. Pediatric causes can be due to steroidogenic defects. Steroidogenic defects. You know what are steroidogenic defects that's going to cause salt wasting and cortisol deficiency? The first one and the most important is the 20-hydroxylase deficiency, which is going to present with DSD as well. XXDSD, we know that. And apart from that, proximal enzyme defects like star defect or a side chain cleaving enzyme desmolase defect, which is going to cause congenital lipoid type of adrenal hyperplasia, which I have discussed already, and they can present with DSDs as well. And we have other enzyme defects like 3-beta HSD defect, which is a proximal enzyme defect again, and certain other enzyme defects like NR5A1 defects, which is a factor that is important for steroidogenesis in the fetus, that is steroidogenic factor 1, details of which we have discussed already. And we have other defects like Smith-Lemeli-Opitz syndrome, which is due to dehydrocholesterol 7 reductase enzyme defect. So the details of which again we have seen in the previous videos itself. And 11B1 defects, that is 11-hydroxylase defect and 17-hydroxylase defect, should not be written here because they usually result in cortisol deficiency, but usually they do not result in salt wasting. In fact, they will be having hypertension due to salt retention because of excess production of DOC, 11-DOC in 17-hydroxylase deficiency and 11B1 deficiency. But 11B2 deficiency will result only in salt wasting but will not result in cortisol deficiency. Similarly, 17-beta HSD3 deficiency and aromatase deficiency will not even result in any adrenal steroidogenic issues. They will be purely gonadal problems resulting in DSD only. These conditions, whatever I have told, may result in DSD, may result in adrenal steroidogenic issues. At the same time, they will be resulting in salt wasting as well as cortisol deficiency. Fine. What are the other pediatric causes? I can split into metabolic defects, and I can split into another disorder called adrenogenital hypoplasia or adrenohypoplasia congenita, AHC. So what are the metabolic defects? One is due to accumulation of very long chain fatty acids. What are the condition that causes accumulation of this very long chain fatty acid? It could be peroxisomal defects. Very importantly, your adrenoleukodystrophy. That's very important for your exams. Adrenoleukodystrophy. You have 3 forms of adrenoleukodystrophy, but the usual defect is in the gene called ABCD4 gene, which is present on X chromosome. So it's going to be an X-linked defect. As I told you, it has 3 forms. A very common childhood form, which usually presents in 4 to 8 years of age, where the patient will be having spasticity and dementia, spastic paraparesis. And we have a adrenomyeloneuropathic form, which will be usually presenting around 21 years of age, where the patient will be having adrenal insufficiency and spasticity only without any dementia. That's a spastic paraparesis. And the third form is the isolated adrenal form, which will be presenting within 8 years with adrenal insufficiency. Apart from that, second defect that can result in accumulation of this very long chain fatty acids causing adrenal insufficiency is Zellweger syndrome. We have been studying Zellweger syndrome from first year biochemistry, where it is due to the problem of the development of these peroxisomes. That is the reason why your very long chain fatty acids will be accumulated. Remember, these very long chain fatty acids can be metabolized only by peroxisomes. That is the problem here. So Zellweger syndrome, this is due to deficiency of peroxisomes in our cells. Fine. Apart from that, there is a second defect which can lead to adrenal insufficiency, that is accumulation of cholesterol esters. Accumulation of cholesterol esters. You know what is the reason for this? I have described this already. That is due to lysosomal lipase defect. Lysosomal lipase deficiency or liposomal lipase defect. We know that this cholesterol is converted to cholesterol ester within the adrenal gland, adrenal cortex, by an esterase enzyme, and this cholesterol ester is converted back to cholesterol by lysosomal lipase enzyme. So if you have a defective lysosomal lipase, the cholesterol ester cannot be converted back to cholesterol, which means the adrenal gland, whenever they need to kick on the steroidogenesis, they will not be able to do that because the cholesterol will be trapped as cholesterol esters. So this will result in a disease called Ullmann disease or Ullmann syndrome, where the patient will be having adrenal insufficiency, and one of a very, very important radiological finding is the adrenal calcifications, that is due to the presence of this accumulated cholesterol esters. Adrenal calcifications, apart from that, they might be having hepatosplenomegaly, they might be having bone marrow involvement causing cytopenias, and they might be having failure to thrive as well. So these are some of the features of Ullmann disease. But in the exam, a neonat with adrenal insufficiency and adrenal calcification is a big clue in exams for the diagnosis of Ullmann disease. And adenohypoplasia congenita itself has its own genetic causes. Like for example, you have this DAX1 and NROB1 defects. As I already told you, this DAX1 is a very, very important transcription factor and very, very important gene for the development of adrenals, gonads, as well as the pituitary. Sometime back only we have seen. So DAX1 or NROB1 defects will result in adrenal problems, gonadal defects, as well as hypopituitarism because of multiple pituitary problems, where it's usually due to this XP21 defects, the specific region, and they can have association with Duchenne muscular dystrophy, and they can have hyperammonemia. This is due to glycerol kinase enzyme defect, which is fairly common in these patients. Second, we have the cyclic dependent kinase N1C defects, which will usually result in a syndrome called as IMAGE syndrome. So IMAGE is an acronym which stands for 4 disorders associated with this condition. One is IUGR, that is intrauterine growth restriction, and EM stands for metaphyseal dysplasia, which is a skeletal defect, and A stands for adenohypoplasia congenita, and GE stands for genital abnormalities. Fine. Then there is another syndrome which is probably due to SMAD9 mutation, but we don't know the exact location of this mutation, which is going to result in a syndrome called Mirage syndrome, where it is a constellation of 6 findings in this syndrome, and Mirage is an acronym for that. So M stands for myelodysplasia, myelodysplastic syndrome, and very peculiarly, the cytogenetics associated with Mirage-related MDS will be monosomy 7. Mirage, MDS, monosomy 7, 3 M's, easy to remember. I stands for recurrent infections, which is also one of the very important reasons for death in these children. And R stands for restricted growth, that is growth restriction or IUGR. And A stands for adrenal insufficiency or adenohypoplasia congenita. And G stands for genital problems. And E stands for enteropathy. Fine. And finally, we have SGPL1 defects. These are very rare, but not important for your exams. As far as exams are concerned, the most important questions will be from 20 oxidase deficiency, Smith-Lemli-Opitz syndrome, Ullmann disease, once upon a time, very favorite Ames question, and probably IMAGE syndrome. So these are the important stuff for exams. Apart from this, it's your knowledge that you have to assimilate all these things. Adult, the most important cause is TB. So first let us see the infectious causes in adults. TB is going to be the most important. Remember, to produce adrenal insufficiency, you have to involve at least 90% of the adrenal glands. Beyond 90% adrenal destruction, your frank adrenal insufficiency will manifest. Below that, it can be a covert adrenal insufficiency, but beyond 90%, there will be a overt adrenal insufficiency. Infections like tuberculosis, leprosy, but TB by far is the most common cause in India and most important as well. And HIV can cause, a lot of fungal infections can cause, syphilis can cause adrenal insufficiency, but TB is going to be the most important, most common in India. And autoimmune disorders are very important for Western nations because of the formation of antibodies against certain enzymes in the adrenal gland. The most important and the most common antibodies are 20-hydroxylase antibodies, where this autoimmune adrenalitis causing adrenal insufficiency can be isolated, or it can be as a part of polyglandular syndrome or which is otherwise I'm going to call it as autoimmune polyendocrine syndrome, which I have discussed already. There are two types of APS, 1 and 2, and IPEX I have described separately. APS type 1 is due to IR gene mutation in chromosome number 21 autoimmune regulatory gene, which is an autosomal recessive disorder. It's a triad of chronic mucocutaneous candidiasis, Addison disease, and hypoparathyroidism. And candidiasis is usually due to immunodeficiency and hyposplenism, and majority of these patients will develop some certain cancers also, which I have discussed already there. APS type 2 is polygenic inheritance. It is much more common compared to APS type 1, which is coming in adolescents and adults very commonly. It's a triad of type 1 diabetes mellitus, especially type 1A diabetes, where there will be antibodies, and you will have Addison disease, and you will also be having final closure of the triad with your thyroiditis, autoimmune thyroiditis, which can be hypo as well as hyperthyroidism, but hypo due to Hashimoto is fairly more common. So you can see that in APS type 1 and type 2, Addison is going to be the common connecting thing. So where both of them will have Addison disease. So whenever you have adrenal insufficiency and primary cause especially, you have to especially rule out this autoimmune constellation. The patient might be having a autoimmune polyendocrine syndrome constellation also. You have to rule out all those things. So be very careful. So if you have autoimmune thyroiditis, rule out Addison disease. If you have an Addison disease, rule out autoimmune thyroiditis also and other autoimmune problems. Apart from that, it can be due to infiltrations and metastasis. But metastasis as such causing adrenal insufficiency is quite rare, and metastasis involving more than 90% of the adrenal gland is also quite rare. But if they ask you most common metastatic source from a primary to the adrenal gland is going to be the lung followed by the breast. This is the most common cancers, but only for exams, but in real time it's not important. Infiltrations by lymphomas, very important, because they can cause, even though they are rare, they can cause more adrenal insufficiency compared to metastasis from lung and breast. And sarcoidosis does not cause adrenal problem. That's what you have to answer in exam, but very rare case reports have been described. But the 4 no's, you have to be very clear about sarcoidosis. That is no cavitation and no caseation, no adrenal involvement, no pleural effusion, and no pneumothorax. Very important points. Apart from that, certain drugs can cause adrenal insufficiency, and there are drugs which inhibit the steroidogenesis, reduce synthesis, or there are some drugs which accelerate the metabolism of cortisol. Because of that, they can produce adrenal insufficiency, and there are some drugs which inhibit the CRH and ACTH release from the pituitary. Because of that, they can produce secondary adrenal insufficiency. But I should not write under adrenal cause, but simply I want to just complete this drugs causing adrenal insufficiency. Drugs that reduce the adrenal steroidogenesis are etomidate. We know that it's an IV drug. We have described in detail in the Cushing syndrome chapter itself. Then we have metirapone, which is an inhibitor of 11B1. We have mitotane, which inhibits multiple steroidogenic enzymes within the adrenal cortex. And we have azoles, especially ketoconazole, which inhibits 2 important enzymes, CYP11A1 and 11B1. Remember, azoles inhibit 11A1 and 11B1. Mitotane inhibits multiple enzymes, including 11A1 and 11B1. Metirapone, very importantly, they inhibit 11B1 only, and etomidate, like azoles, it will inhibit 11A1 and 11B1. And what are the drugs that increase metabolism? Because of that, you might result in adrenal insufficiency. Most important in our setting will be rifampicin, because I told you the most important, most common cause in India is tuberculosis, where the patient might be having covert adrenal insufficiency. Giving rifampicin may make that covert adrenal insufficiency into an overt adrenal insufficiency by accelerating the cortisol metabolism and destroying the cortisol rapidly. That's why that rifampicin in India makes a lot of sense. And we have some other drugs like phenytoin, antiepileptics. There is nothing to explain in this, and other drugs like phenobarbital also can do the same, but phenytoin and rifampicin are the most important. Drugs that reduce the CRH and ACTH release from the pituitary is megestrol. Remember, megestrol vaguely inhibits the pro-convertase enzyme also, and it vaguely reduces the CRH release and ACTH release also. Usually it is given as a appetite stimulant. How it stimulates the appetite is by reducing the POMC formation and POMC cleavage. Because of the same, they might result in reduced MSH production. So action on MC4 receptor will be less, because MC4 receptor is a very important anerosogenic pathway. Blocking the MC4 receptor's activity will result in more appetite and more eating. So that is why this megestrol is often used as an appetite stimulating agent, but it can result in reduced ACTH and CRH release, usually causing a central adrenal insufficiency like picture. I should not write it here, but still just for the completion's sake, I am finishing it off. Apart from that, there are some other cause of adrenal insufficiency like hemorrhage and infections. And this constellation of hemorrhage due to infection and DIC is what we refer to as a Waterhouse-Friderichsen syndrome. Even a second year student will be knowing this Waterhouse-Friderichsen syndrome. But they will be typically remembering only one cause, that is Neisseria meningitidis, that is meningococcemia, meningococcal sepsis causing this Waterhouse-Friderichsen syndrome causing adrenal insufficiency and due to adrenal hemorrhage. But there are some other bacterium which can cause the same, like pneumococcus, Haemophilus, and Staphylococcus aureus as well. But in exam, always think about Neisseria meningitidis. Patient with altered mental status, neck stiffness, and photophobia, coming with diffuse rashes in the body, having adrenal insufficiency features like low sodium, high potassium, and renal failure, especially pre-renal type, and hypotension. Along with that, they are having shock. Think about Neisseria meningitidis causing adrenal insufficiency due to Waterhouse-Friderichsen syndrome, which is a fairly common case scenario that you'll be getting in exams and USMLE exams. How they will be presenting? Because of the adrenal hemorrhage, they'll be coming with a sudden onset bilateral flank pain. Usually, they'll be having a sudden onset bilateral flank pain and mass. Along with it, they might be having hematuria. Usually, the hematuria will be microscopic hematuria. This will be the picture. This is how the patients are going to present. But one of the important closest DDs for this sudden onset bilateral flank pain and microscopic hematuria is bilateral renal vein thrombosis, which can happen in patients who are suffering from nephrotic syndrome, especially those who are suffering from membranous glomerulonephritis. This is a very, very important DD, where in patients who are suffering from nephrotic syndrome, and because of that, if they get bilateral renal vein thrombosis, they will also be coming with this flank pain, flank mass, and renal failure. But more importantly, they will be having macroscopic hematuria and a gross hematuria than a microscopic hematuria. Clear? At the same time, the confirmatory investigation will be renal vein Doppler. Obviously, that is going to clinch you the diagnosis. And treatment of choice for renal vein thrombosis, anticoagulants like Clexane. So that's a completely different picture, but it's a very close differential diagnosis as far as students thinking in exams are concerned. And another very important cause is going to be on SERSI, that is called critical illness related corticosteroid insufficiency. What is the problem with critical illness? The patient might be suffering from extreme amounts of stress because of the illness criticality that they're going to suffer from, and because of the same, the cells are going to consume extremely high amounts of cortisol, and because of the same, your amount of cortisol production may be much lesser compared to the cortisol consumption by the cell. So that is the reason this is a relative cortisol deficiency, so which is due to cortisol consumption that is happening too much because of the critical nature of the disease. So this is due to cortisol consumption. So that is the reason. So this is what we refer to as SERSI, where you might be needing to supplement with cortisols. We have seen a lot of causes, right from central to peripheral causes to receptor causes, but we have forgotten one of a very, very important cause. In fact, one of the very common cause in the previous past, but right now it's decreasing because of awareness. That is called adrenal insufficiency due to exogenous glucocorticoid withdrawal. Exogenous glucocorticoid withdrawal. I've told you hint about this disease in the Cushing syndrome chapter itself, but this is quite important. So as I already told you, what is the problem in exogenous glucocorticoids? We see the axis first, ACTH, CRH, and this is going to work on the adrenal glands to produce cortisol. The cortisol is the one that has to give feedback to the CRH and the ACTH axis. Here you are supplementing with some powerful exogenous glucocorticoid, which is definitely going to inhibit the CRH and ACTH axis. And over time, if you give for a longer time, this CRH and ACTH axis will go for atrophy. And this atrophy of the CRH ACTH axis usually takes around 2 to 6 weeks. And consistent low ACTH levels in the blood will result in atrophy of the adrenal glands, especially of the zona fasciculata, which will usually happen around 6 to 8 weeks, after 6 weeks. So which means any steroid exposure for more than 2 to 3 weeks is a risk factor for developing adrenal insufficiency if you stop them suddenly, because this axis that have been atrophied will take some time to recover. So till that time you have to taper and stop the steroids gradually rather than stopping the steroids suddenly. But not all steroid doses will result in this. Let us see what are the guidelines tell. Like for example, what are the patients who are going to have high risk of developing or a definite risk of developing adrenal insufficiency due to withdrawal of exogenous glucocorticoids, and what are the patients who have intermediate risk, and what are the patients who are having no risk of developing adrenal insufficiency due to stopping exogenous glucocorticoids. First, high risk patients or definitive risk patients with Cushingoid features already, which means already they are exposed to high level steroids, that's why they are having Cushingoid features. In these patients, if you stop the steroid suddenly, it's a very bad thing, so you should not do that. Or patients who are taking any steroid with a prednisolone equivalent dose of more than or equal to 0.5 milligram per kilogram per day, at least for more than 2 to 3 weeks. Clear? So this is a very, very important dose again. Or if the patient is having nighttime dose with the prednisone equivalent of more than 0.2 milligram per kilogram per day for more than 2 to 3 weeks, which means this is for nighttime dose. That's why taking steroids in the night is having even more problems. That's why I explained to you in the Cushing syndrome chapter itself. These patients are going to have a high risk of developing adrenal insufficiency if you stop them suddenly. So stop them gradually, taper them and stop gradually. Don't stop suddenly. Some patients are having no risk of developing this steroid withdrawal related adrenal insufficiency. What are those patients? Those patients are ones who have received treatment for less than 2 to 3 weeks. Especially this 3 weeks is very important, more than 2 weeks, because risk is more with 3 weeks. So 2 to 3 weeks. And second, they have taken only alternate day dosing of prednisolone, that too in the morning and not in the night, of less than 0.2 milligram per kilogram per day. Only in the morning they have been taking. So these patients are at usually no risk of developing adrenal insufficiency, and you can stop steroids abruptly in these patients. There is no need to wait and gradually stop. And those patients who are at intermediate risk, what are the patients that are intermediate risk? Those who are taking prednisolone dose at or any equivalent steroid with a prednisolone equivalent dose of 0.2 to 0.5 milligram per kilogram per day for more than 3 weeks. And at the same time, they should not have any nighttime dosing. Nighttime dosing increase the risk multiple times. If they are not taking nighttime dosing and they have taken the intermediate range of 0.2 to 0.5 milligram per kilogram per day, but they have taken for more than 3 weeks, these patients, we don't know whether they will develop adrenal insufficiency if you stop or not. Either your option is to taper and stop in case of if you suspect a risk, or you can do alternatively ACTH stimulation test, which we'll be discussing in detail in some time, because this is going to be the cornerstone of our discussion in this topic. ACTH stimulation test, and then you can decide. If ACTH stimulation test is showing adrenal insufficiency, then you can taper and stop. If it's not showing adrenal insufficiency, you can taper abruptly. Clear? But remember, whenever in doubt, always taper the steroid rather than stopping them abruptly. So these are the guidelines, but remember, anything less than 7.5 milligram is very safe even if you take for a long run. Anything if you take for more than 20 milligram prednisolone equivalent, it's very high risk. 7.5 to 20, you don't know. Overall dose, I'm telling, not per kilogram per day dose. Overall dose more than 20 to 40 milligram for more than 2 to 3 weeks especially is always a risk. Less than 7.5 milligram, even for longer run if you take, it's unlikely to cause adrenal insufficiency. 7.5 to 20 is a usual, like gray area. So you cannot really tell as far as adults are concerned. So we have now discussed in detail about the etiology. Now let us summarize what are the differences between them, the primary cause, secondary cause, and the receptor level defect. So primary adrenal insufficiency, here the adrenal will be the problem, and secondary adrenal insufficiency where pituitary hypothalamic region will be the problem, or receptor level defect. That is nothing but ACTH resistance. So primary adrenal insufficiency, what will be the cortisol levels? Cortisol levels will be definitely low in all these three things. That's why we are putting it under adrenal insufficiency in the first place. And what will be the ACTH levels? ACTH levels in primary will be high because the primary problem here is low cortisol that will stimulate the pituitary to produce increased amounts of ACTH. And because of the same, these patients will be having hyperpigmentation. In secondary adrenal insufficiency, the ACTH will be low. Remember, this is the primary problem, even though it's called a secondary adrenal insufficiency. And because of the low ACTH, they'll be having low cortisol. And hyperpigmentation will not be there because of the low ACTH production. And receptor level defects will be having increased ACTH because it's ACTH resistance. To overcome the resistance, you have to produce more ACTH, and obviously they will be having hyperpigmentation for the same. Fine, all right. Then we have aldosterone levels. Remember, aldosterone levels are actually maintained by the renin-angiotensin axis. In primary adrenal insufficiency, obviously the aldosterone levels will be low because of the involvement of the adrenal gland as such, and the zona glomerulosa also will be involved. So because of that, aldosterone levels will be low. For the same reason, they will be having salt wasting, dehydration, hypovolemia, as well as other electrolyte disturbances like hyperkalemia. Patients who are having secondary adrenal insufficiency, these patients generally tend to have a normal aldosterone levels because, as I told you, ACTH deficiency will not lead to aldosterone deficiency because it's covered up by the renin-angiotensin axis, which means there will be no salt wasting, no hyperkalemia, which means they will be having a normal serum potassium. Similarly, patients who are having ACTH resistance, it is like a problem in the ACTH receptor. So only ACTH axis is a problem, but renin-angiotensin aldosterone axis is normal. So which means aldosterone levels are normal, which means once again these patients will not be having any salt wasting or hyperkalemia, and they will be having a normal serum potassium only. Apart from that, what will be the DHAS levels? Remember, DHAS levels will be decreased universally in all these situations because ACTH is also important for DHAS production. So DHAS will be decreased in all these situations. We will be seeing the effects of low DHAS in some time. And the treatment is going to involve addition of both glucocorticoids and mineralocorticoids in patients with primary adrenal insufficiency, because we know in primary adrenal insufficiency there will be both aldosterone as well as cortisol deficiency. So you have to replace the glucocorticoid as well as the mineralocorticoid. But please do remember, as I already told you, if your hydrocortisone dose you are using, if it's more than 50 milligrams per meter square per day, you need not replace mineralocorticoid separately. Clear? And for secondary adrenal insufficiency, glucocorticoids alone is enough. And for ACTH resistance, again, glucocorticoids alone is enough because in these conditions, you don't have salt wasting. But remember, addition of DHAS is optional, especially if the patient is having poor quality of life, especially in females. But this is a very, very controversial entity because in all these three disorders, DHAS levels will be low, like cortisol. And what will be the signs of undertreatment? What will be the signs of undertreatment? Undertreatment will result in salt wasting, which means the salt wasting will not resolve at all. The urinary sodium will be very high. Patient will be persistently dehydrated. They will not gain the weight. So that will be the sign of undertreatment. But remember, in children, especially who are suffering from congenital adrenal hyperplasia, especially due to 21-hydroxylase deficiency, you have to be very careful because this will result in androgen excess state. And this elevated DHAS might result in virilization of the child. That's very, very important. But this low DHAS, I meant only for other cause of adrenal insufficiency, but in certain CAH patients, there might be increased DHAS also. And that is the reason for virilization, which I have been seeing till now. So be very careful. And what will be the sign of undertreatment in case of your receptor level defects and secondary adrenal insufficiency? Usually the sign of undertreatment will be just fatigue and lethargy, nothing else. They won't develop salt wasting. Now we are moving on to the clinical features of this hormone deficiencies. What will be the clinical features due to cortisol deficiency? What will be the clinical features due to aldosterone deficiency? And what will be the clinical features due to DHAS deficiency? Very controversial, especially the DHAS. So low cortisol will usually result in very vague symptoms like weakness, fatigue, weight loss, vomiting, and abdominal pain usually happens during salt wasting crisis, not during usual stages, but whether the abdominal pain is due to low aldosterone, low cortisol still needs to be elucidated. And it can result in other electrolyte problems like hypercalcemia, hypoglycemia as well as hyponatremia. You might be asking why you get hyponatremia in a patient who is suffering from cortisol deficiency. But well, I told you this hyponatremia is due to SAADH. I have told you multiple times, which will be usually euvolemic type. If it's a pure and true cortisol deficiency alone. The reason we know pituitary is going to release ACTH, ACTH is going to release cortisol. This cortisol should give feedback to the pituitary and the hypothalamus. But remember, one of the important triggers for this ACTH release from the pituitary is ADH, that is coming from the hypothalamus. So your cortisol gives feedback to the vasopressin as well. Suppose if you have a low cortisol, this feedback will be lost and you will produce more AVP, and that is the reason for development of SAADH in these individuals. Apart from that, low cortisol itself can result in a variety of hematologic issues, like they can result in mild anemia, they might result in neutropenia, they might result in eosinophilia, and they might result in lymphocytosis. Very important. So especially this mild anemia and neutropenia are very commonly asked in exams. Along with eosinophilia and lymphocytosis, some exams do ask that. Effects of low aldosterone. Low aldosterone typically results in salt wasting. Salt wasting is the most important as far as low aldosterone is concerned. So which means the patient will be hypovolemic because of the salt wasting. Where they are losing the salt? In the urine. There will be increased urinary sodium, and there will be a hypovolemic hyponatremia. There will be a reduced serum sodium. One of the important evidences of hypovolemia in a patient who is not in crisis will be orthostatic hypotension. Orthostatic hypotension. But if the patient goes for salt wasting crisis, they will develop shock and severe hypertension. Remember, for that matters, low BP and shock can happen with cortisol deficiency itself, but quite rare. The patient is having both aldosterone and cortisol deficiency, that's more dangerous. They'll go for rapid shock. But only cortisol deficiency, rare shock, but still possible. But aldosterone deficiency, shock still possible, but usually aldosterone deficiency will not happen isolatedly. It will be along with cortisol deficiency, like in primary adrenal insufficiency. Apart from that, they might be having hyperkalemia. We know that why low aldosterone cause hyperkalemia. We had a detailed discussion in the beginning of the endocrine itself. And they might be having metabolic acidosis. And this metabolic acidosis is usually NAGMA, that is normal anion gap metabolic acidosis. And low DHAS related symptoms are highly controversial, very common in females, because females, the adrenal androgens play a very vital role in the pubic and axillary hair development and libido, because the adrenal androgens are the maximum source of androgens in females, 50 to 60%. Remaining 40 to 50% is coming from the ovary as well. But adrenal androgens form a very predominant source of androgens with regards to females. That is the reason why in males, the effect of low DHAS is highly insignificant. But in females, it can result in diminished axillary and pubic hair. I should not write loss, but diminished axillary and pubic hair. At the same time, they might result in reduced libido as well. But as I told you before, this combination of cortisol and aldosterone deficiency is going to be more problematic. So this combination of aldosterone deficiency and cortisol deficiency is going to be dangerous, because they can result in salt wasting crisis, otherwise referred to as Addisonian crisis. Why it is called Addisonian crisis is because combination of aldosterone deficiency and cortisol deficiency will usually happen in Addison disease, that is primary adrenal insufficiency. That's why it's also referred to as Addisonian crisis. Remember, salt wasting alone causing a shock is very rare, and similarly, cortisol deficiency alone causing a shock is also quite rare. But combination will often result in shock. Even for a minor illness, they can result in shock. That is the first point that you have to know. Whenever the patient presents with salt wasting crisis, there will be shock, and this shock will be out of proportion to the underlying clinical illness. So which means patient might have got just a URI and they cannot even cope up with that URI and they're presenting with a shock. Patient have got 3 episodes, 4 episodes of diarrhea and vomiting, and they cannot cope up with that stress also, and they will go for a shock. So symptoms and especially the shock that is out of proportion to the underlying illness. And all the symptoms will be out of proportion. Like this patient might be having abdominal pain and vomiting, severe abdominal pain and vomiting, and they can even have tenderness in the abdomen on palpation because of the serosities. We don't know why they cause abdominal pain, whether cortisol component or aldosterone component, but abdominal pain is there. And many of these patients will have classic electrolyte disturbances. Classic electrolyte disturbance because of combination of aldosterone loss and cortisol loss. Like they will be having low serum sodium. This hyponatremia is usually hypolimic. Remember here it is due to salt wasting, due to aldosterone deficiency. And they might be having hyperkalemia, again due to aldosterone deficiency. And they might be having severe hypotension, as I told you already, that is due to combination. And they might be having slight hyperglycemia, slight hypercalcemia, that is due to cortisol deficiency. And they might be having hypoglycemia, that is again due to cortisol deficiency. And they might be having mild increase in TSH. This is a very, very important point. This again is due to cortisol deficiency. Remember, cortisol gives feedback to the TRH axis as well. So low cortisol might result in a slight increase in the TSH and the TRH. But please do understand that this increased TSH will never lead to hyperthyroid state. Though usually the TSH will be in the range of 6 to 7, subclinical range only. It will never go beyond 10. So you should not take it as a hypothyroid, evidence of hypothyroidism. This high TSH is an effect of low cortisol rather than a hypothyroid cause. So don't think about hypothyroidism in this regards. At the same time, these patients may have a very high urinary sodium, suggesting that this patient is having salt wasting, that is due to aldosterone deficiency. And usually there will be some underlying precipitating cause for developing this adrenal crisis. It could be coming in the form of some very minor illness to major illness, minor to major infection, anything can cause. But in exam, usually they will give history of very minor infection and the patient will come with shock. That itself will tell you that the patient is suffering from Addisonian crisis. Or the patient will be having some stressful events, for example, surgery. Stressful events like surgery, even minor surgeries can precipitate shock, even an endoscopy precipitating a shock. So that's definitely a sign of Addisonian crisis. And at the same time, certain drugs can precipitate Addisonian crisis. For example, giving a levothyroxine is very, very important because many times patient will not have a Addisonian crisis, shock, but many practitioners, they will be seeing this mild increase in TSH. Patient will be complaining of fatigue and lethargy. You might be thinking this mild increase in TSH caused because of subclinical hypothyroidism. Patient is having this fatigue and lethargy, and the practitioners start giving this levothyroxine. If they start giving levothyroxine, that will increase the basal metabolic rate and energy demands in the body, which is actually a state of stress in the body. So that will increase the stress in the body, and the patient may go for overt adrenal insufficiency after starting with levothyroxine. So that is why whenever before starting levothyroxine, always rule out adrenal insufficiency, especially when you are having a high turnover setting. So when you are having a more patient turnover in tertiary care center, rule out adrenal insufficiency, because this hypothyroidism could be a part of an autoimmune polyendocrine syndrome. Type 2 is very common in the community, and these patients may have a underlying covert adrenal insufficiency. When starting levothyroxine, it may become a overt adrenal insufficiency. So that is why there is a mnemonic called A before T. Even in a patient who is suffering from mixed edema, this A before T mnemonic is very, very important, because A means adrenal, before T, that is thyroid, which means always replace the adrenal deficiency first, that is hydrocortisone, then go for the thyroxine, even in a patient with mixed edema. Even in a patient with adrenal crisis, this rule applies. Even if you want to replace thyroxine as a part of polyglandular syndrome, where the patient is also having significant levothyroxine deficiency, in those patients also, better to replace hydrocortisone first and thyroxine next. This is very, very important rule in critical care. Always, before giving thyroxine critical care for a thyroid deficiency, always replace hydrocortisone first, because patient may have a covert adrenal insufficiency as a part of polyglandular syndrome, which may turn into a overt adrenal insufficiency after starting levothyroxine. And second, many drugs are there, but more importantly, I can talk about rifampicin, especially in tuberculosis, which we have discussed in detail in many sections in the past as well. And other drugs like etomidate, if you are using in ICU for induction for patient with Addisonian defect, may result in development of crisis. So I'm not going to discuss in detail. So these are some of the precipitating factors. But what are the deadly things? Deadly things is starting thyroxine in a patient with adrenal crisis. Very deadly. You should not do that. And second, even more deadliest thing is like if a patient is coming with abdominal pain and vomiting, and if you take this patient for surgery, thinking that it's a case of surgical abdominal pain, that's like definite death of the patient, which means patient will not cope up on surgical table in the operation theater, and the patient is going to die on table because they cannot increase their BP and they'll go for crisis without cortisol. So even if the patient is having appendicitis and the patient is having adrenal insufficiency, always replace with hydrocortisone first, give a 100 milligram shot of hydrocortisone in adults, then take the patient for surgery if at all you in doubt. So that's what anesthetist will do. A trained anesthetist will definitely give hydrocortisone if he suspects adrenal insufficiency, even if he thinks it's a surgical case. And very commonly, they tend to miss the hyperpigmentation, which is very important. Because many of the times, your adrenal crisis will be associated with primary adrenal insufficiency, which will definitely have this hyperpigmentation if it is long-standing. So where you look at this hyperpigmentation, especially in the non-sun exposed areas. It can be seen in sun exposed areas, but if you see in non-sun exposed areas, it's relatively more specific. For example, in the gums, in the mouth, in the palate, in the undersurface of the tongue, and undersurface of the nipples, and in the areas of pressure sites, especially when you're wearing innerwears, that strap regions like bra strap regions, underwear strap regions, and in the nails, especially in the toenails and the fingernails. If you see hyperpigmentation, it becomes relatively more specific. And in this patient who was suffering from long-standing tuberculosis, who had an adrenal involvement, who had a poor glucocorticoid replacement, you can see the fact that this patient is having a patchy hyperpigmentation in the gums. Having black gums is different, that is based on ethnicity, but having patchy hyperpigmentation of the gums is not very normal. And you can see in the undersurface of the nipples, this patient is having hyperpigmentation, and in the nails, this patient is having hyperpigmentation again, which is suggestive of adrenal involvement in this case, primary adrenal insufficiency, and hyperpigmentation is due to high ACTH in this regards. And let us move on to the testing strategies. We have two tests as our armor in testing adrenal insufficiency. One is the serum cortisol assays, where I'll be testing the total serum cortisol, and you have to always keep in mind about the effect of cortisol binding globulin on the total serum cortisol, which I have discussed in detail in the previous video itself. And testing also will involve ACTH stimulation test, which is a very, very important test as well. So serum cortisol, ideally, it's better do at 8 a.m. because that is the time where serum ACTH and cortisol will be at its peak. And if you prove at that time, if the patient's cortisol is low, then you can tell there is a blunting of diurnal rhythm and the patient is probably suffering from adrenal insufficiency. But in times of stress like ICU or critical care illness, then you can think about random cortisol also. But 8 a.m. serum cortisol usually is the best. Suppose if you are seeing lesser values than the cutoff, you can think about adrenal insufficiency. So let us see the values first. So remember, what will be the values that will tell you that the patient is having a definite adrenal insufficiency, and what will be the cortisol values that will be indeterminate, which means there will be borderline values. What are the cortisol values that will tell definitely it is normal and it rules out any possibility of adrenal insufficiency. Number one is the 8 a.m. values. 8 a.m. values, if it is less than 3 microns per deciliter, it is definitive for adrenal insufficiency. Intermediate, borderline values tell you that if it's 3 to 18, it is indeterminate, and if it's more than 18 microns per deciliter, it is sure that the patient is not having adrenal insufficiency. And at times of stress, like in ICU or in the patient who is suffering from adrenal crisis, in this scenario, any value less than 5 microns per deciliter tells you that the patient is suffering from definite adrenal insufficiency. If it's in the range of 5 to 18 microns per deciliter, it is indeterminate or borderline. If it's more than 18 microns per deciliter, even in times of stress, it tells you it's a normal range and rules out possibility of adrenal insufficiency. And number 3, after ACTH stimulation, I will be talking about ACTH stimulation in some time, or any dose of ACTH stimulation. After that, if you see values less than 18 microns per deciliter, because ACTH is a powerful stimulator of cortisol production. If it's less than 18, after ACTH stimulation, obviously we know it's a provoking test. So in provocation test, you are having a less value, means it's a deficiency. So it's a adrenal insufficiency. So there's no indeterminate value. Anything more than 18 is suggested to be normal and rules out any possibility of adrenal insufficiency. Coming to the ACTH stimulation test, we have two types of tests. One is called a low dose ACTH stimulation test and high dose ACTH stimulation test, or we call it as a standard dose ACTH stimulation test. For this purpose, we'll be using synthetic ACTH. That is why some books will give you this as a synacthen test. That's a synthetic ACTH test. Low dose ACTH test is also referred to as a short synacthen test, and standard dose ACTH test is also referred to as a usual synacthen test. In low dose ACTH stimulation, we'll use only 1 microgram of ACTH. In standard dose ACTH stimulation, we'll be using 250 microgram of ACTH. Clear? So why there is a discrepancy? Why you want two different tests? For this, you have to understand the sensitivity and specificity cutoff. Low dose ACTH test is more sensitive but less specific, whereas standard dose ACTH stimulation will be a little less sensitive and more specific. Why this sensitivity and specificity is important? Because there are two disorders we know, primary and secondary. Let us see what will happen in primary and secondary. First, let me write the HP axis first. This is something which I have been discussing for quite a while, for a long time. So let us assume this is a primary adrenal insufficiency, this is a secondary adrenal insufficiency. In primary adrenal insufficiency, you know the problem is in the adrenal gland. You have a low cortisol. Because of that, there will be stimulation of the pituitary to produce more ACTH. So in this condition, if you give a ACTH stimulation, already there is high ACTH. Add on to that, whether you give a low dose ACTH stimulation or high dose ACTH stimulation, there will be absolutely no response. Because already the adrenal gland is gone, it's not going to respond to any amount of ACTH. So there will be no increase in the cortisol. But on the other hand, if you are using in a secondary adrenal insufficiency, the problem is low ACTH. And this low ACTH in the long run can result in adrenal atrophy. I told you, zona fasciculata atrophy, and the ability of the zona fasciculata to respond to any ACTH further will be diminished here. But the problem is, for adrenal atrophy to take place, it takes around 6 weeks. I told you already, it takes around 6 weeks. Suppose if you are testing within 6 weeks, if you give a low dose ACTH stimulation test, they won't respond because the response will be poor. There won't be any response. But if you give a standard dose ACTH stimulation, there might be a response. There might be increase in serum cortisol because you are using this test within 6 weeks where the adrenals have not gone for atrophy completely, which means they are still in the verge of responding something to exogenous ACTH. So that is the reason why low dose ACTH is more sensitive, because it picks up even early secondary adrenal insufficiencies also. That is the reason. After 6 weeks, whether you give low dose or high dose, the adrenals would have gone for atrophy, so they will not respond to ACTH. So that's not a problem. So this increased sensitivity means this low dose ACTH stimulation test can pick up this early secondary adrenal insufficiencies or early central adrenal insufficiencies. So in those conditions, this low dose ACTH stimulation might be a bit helpful, but overall there is no much difference. Indians always tend to go for this standard dose ACTH stimulation test only. So what will be the peak value of ACTH? Remember, the peak cortisol is reached at 30 minutes, usually at 20 to 30 minutes in case of short synacthen test, that is low dose ACTH stimulation. In case of standard dose ACTH stimulation, the peak value is reached at 30 minutes. When will you do the test for serum cortisol? Serum cortisol assay, when will you be doing after ACTH stimulation? Usually, here you have to do at 30 minutes. Here you have to do two tests, one at 30 minutes and second at 60 minutes, because it starts rise at 30 minutes itself in a standard dose test itself. If they ask you the best time for seeing a serum cortisol after ACTH stimulation, it's 30 minutes for both. That's the best time, standardized time. After ACTH injection, after 30 minutes, you can test for serum cortisol. But especially when you're living in an endocrine rich setting, it's better to test for both 30 minutes and 60 minutes serum cortisol if you want to be very clear cut and sure. So in our hospital, we usually test both 30 minutes as well as 60 minutes serum cortisol after giving standard dose of ACTH, that is 250 microgram. The advantage of ACTH stimulation, it can be done in any time of the day, irrespective of your fasting or 8 a.m. status or 12 a.m. status doesn't matter. So it's very, very useful, especially in critical care settings and especially when the patient is coming in crisis. It will tell you a very, very good information about patient is having adrenal crisis or not. And it needs just a single sample usually, and the best sample will be at 30 minutes. That's it. Clear? 60 minutes you can do optionally if you are living in a endocrine rich setting, especially if you are doing a standard dose ACTH stimulation, but single sample is enough, best done at 30 minutes. That's it. So these are the two tests which are in our hospital very commonly available, very easy to do as well. And as an icing on the cake, let us see the approach to a patient who is suffering from suspected adrenal insufficiency. So whenever a patient is suffering from suspected adrenal insufficiency, we have to see whether the patient is in salt wasting crisis or not. So if the patient is in salt wasting crisis, then which means they must be having low BP, and don't forget to look for hyperpigmentation in this patient with salt wasting crisis, because very commonly it will be due to primary adrenal insufficiency. First, stabilize the patient because they will be in shock. Obviously, you have to use normal saline 0.9% NaCl as the replacement fluid of choice, and you might be needing liters of NS to stabilize these guys. Apart from that, you have to see whether this patient is a known case of adrenal insufficiency or not, which you have to turn the records back and see, ask the patient's records, and they might be having a note which might be saying patient is a known case of autoimmune polyendocrine syndrome or a polyglandular syndrome type 2, where the diagnosis is straightforward. So in this condition, if the patient is a known case of adrenal insufficiency, then you can start with hydrocortisone because there is no diagnosis needed. Already the patient is a known case. Hydrocortisone usually is given at a dose of 50 to 100 milligram 6th hourly IV. Or alternatively, you can give as a bolus and infusion. So usually we give a 50 milligram per meter square as an IV bolus, followed by you can give 100 milligram per meter square per day as an infusion for 24 hours. This is also an alternative dosing regimen, but in practical settings, we try to give in an adult 50 to 100 milligram every 6th hourly. That's the dose. Remember, hydrocortisone itself has a good mineralocorticoid activity if it's given at a dose of more than 50 milligram per meter square per day. So definitely at this dose, surely it should cover the salt wasting because it's having a mineralocorticoid effect as well. Suppose if the patient is not a known case, this is where the problem is. Here you cannot use hydrocortisone because why, I'll tell you in some time. Here you have to give a glucocorticoid, but you have to start only after taking a random cortisol. So try to do a random serum cortisol in this regards, and then give, but don't waste time. But if you don't have a random serum cortisol, straight away start with glucocorticoid. You should save the life rather than the diagnosis. Life is more important than diagnosis. But if you have facility, first take random serum cortisol, then give a glucocorticoid and a mineralocorticoid separately. Here the glucocorticoid, what will be following is dexamethasone, usually 2 to 4 milligram IV 6th hourly, and the mineralocorticoid usually will be preferring is fludrocortisone because here this dexamethasone, we know it doesn't have any mineralocorticoid effect. Fludrocortisone dose is usually 0.05 to 0.1 milligram. You can give either OD or a BD dose depending on the salt wasting condition and the response. But why we are using dexamethasone and fludrocortisone separately here? Because here the patient is not having a diagnosis. That's why. You don't know whether the patient is a known case of adrenal insufficiency or not. In this regards, you have to see the serum cortisol values. What is the serum cortisol value? If it's less than 5 micrograms per deciliter, because the patient is in stress, the patient is coming in crisis, that hypotension itself is a huge stress to the body. Since the patient is in stress, less than 5 as a cutoff. If it's less than 5, it confirms the diagnosis of adrenal insufficiency. In this condition, you can transform this dexamethasone. Either you can continue with dexamethasone and fludrocortisone, or it's better to change to hydrocortisone. There is no problem because you know this is a straightforward case. Suppose if the patient is having level of more than 18 micrograms per deciliter, this definitely rules out any possibility of adrenal insufficiency. It's unlikely to have adrenal insufficiency in this regards. So you can stop the steroid replacement. There is no need. It's unnecessary, which means you have to evaluate for other causes of hypotension and shock. It's unlikely to be adrenal insufficiency. But if the levels are in the range of 3 to 18 micrograms per deciliter, 5 to 18 microns per deciliter. This is an indeterminate value and this is a borderline value. In this condition, definitely you have to do ACTH stimulation, ACTH stimulation test. We generally do a standard dose ACTH stimulation where we'll be doing 250 microgram of ACTH, and after 30 minutes, or even at some centers you can use 60 minutes as cutoff also, but in general we'll be using 30 minutes cutoff. At 30 minutes, see the serum cortisol again. The advantage of ACTH stimulation, at any point of the day you can do ACTH stimulation, so that's a big advantage. So after 30 minutes, check the serum cortisol. If it's less than 18, it confirms it's a adrenal insufficiency, and usually it's better to change to hydrocortisone. Or you can continue with dexa and fludrocortisone also, I don't have any problem, but it's better, like hydrocortisone is single drug which will cover both glucocorticoid activity as well as mineralocorticoid activity. So change to hydrocortisone. If it's more than 18, it rules out adrenal insufficiency. So in this regards, it's better to stop the steroid replacement. Better to stop the steroid replacements. That is the reason why we are using dexamethasone in the beginning. Suppose if you are going to get a borderline value. Suppose if you are going to get a borderline value and you have used a hydrocortisone already. You are not used dexamethasone. So what you are doing with the ACTH stimulation test is to check for the serum cortisol. So if you have used a hydrocortisone in the beginning itself, so now once you are going to check the serum cortisol after the ACTH stimulation test, that hydrocortisone what you have given IV might interfere with the cortisol assays, because hydrocortisone and cortisol are almost the same. They are going to interfere with your cortisol assays. So that is the reason why we give dexamethasone, which is not going to interfere with your cortisol assays. That is why in this condition it's better to prefer dexamethasone. Suppose some people might ask, I don't have a random serum cortisol at that point, which means I don't have time to give random serum cortisol. I'm in an emergency to push glucocorticoid first. So in that setting, if you don't know the diagnosis, give dexamethasone, give fludrocortisone straight away. You don't have this random serum cortisol value, so forget it. Straight away give ACTH stimulation. Straight away start with ACTH stimulation, and if it's more than 18, you rule out adrenal insufficiency, and if it's less than 18, confirm it's a adrenal insufficiency. That's it, very simple. If you don't have random serum cortisol, approach like this. You just give glucocorticoids and fludrocortisone first, dexamethasone, fludrocortisone first, then you perform ACTH stimulation whenever it's feasible. If it's more than 18, rule out, less than 18, confirm. That's all. This is also very logistic approach. Suppose if the patient is not in crisis. This is a very easy scenario. So here I'll be doing a 8 AM serum cortisol. You have some time, aram se you can do. 8 AM serum cortisol, next day morning you can do. If the 8 AM serum cortisol value is less than 3 microns per deciliter, that confirms its adrenal insufficiency. So you don't need any other testing. Suppose if it is more than 18, that rules out adrenal insufficiency. Once again, you don't need any testing for this. Suppose if the 8 AM serum cortisol is in the range of 3 to 18 microns per deciliter, this is where the problem is. Here the patient will not be in steroid already. So in this condition, you can do a ACTH stimulation test. ACTH stimulation test, low dose or a high dose, it's your choice. In both the stimulation test, types of ACTH stimulation test, the cutoff is the same, that is 18. If it's less than 18, after ACTH stimulation, 30 minutes of ACTH stimulation, it confirms it is adrenal insufficiency. If it is more than 18, it rules out patient is having no adrenal insufficiency. Rules out adrenal insufficiency if it is more than 18. That's it. So obviously it is assumed here if the patient is not in crisis and you are only suspecting adrenal insufficiency means obviously in this setting the patient will not be having received any steroids. So it's better to do a ACTH stimulation straight away, and after 30 minutes you take the blood sample and test. Fine. So this is how you approach a patient with adrenal insufficiency. But the replacement doses I've told you already. Let me tell you the dosages once again. Obviously, like for adrenal insufficiency, hydrocortisone is the best replacement instead of other glucocorticoids, because hydrocortisone itself covers the mineralocorticoid action also. In case of a central insufficiency, then you can try only a glucocorticoid agent like dexamethasone or a prednisolone, but hydrocortisone is usually the safest and best replacement steroid for case of adrenal insufficiency. Usual dose of adrenal insufficiency, dose of hydrocortisone adrenal insufficiency is approximately 15 milligram per meter square per day. This will equate roughly to 15 to 25 milligram per day in case of adults usually. And this has to be given either BD or TDS. It's better to prefer a TDS dosing. And usually we'll give half in the morning, 1/4 in the afternoon, and remaining 1/4 in the evening or in the night. Clear? So this is how we give a dosing. This is the better dosing because hydrocortisone is better to give 3 times a day because of the waxing and waning effect. To avoid that, currently this dual release preparations are available where one shot of hydrocortisone will be released immediately and remaining hydrocortisone will be released slowly over a period of time to prevent that waxing and waning effect. So I mean, that is beyond the scope of the discussion right now. So that is proper practice-based discussion. So right now I'm not going to discuss. BD dosing means you are going to give 3/4 of the dosing in the morning and 1/4 of the dosing in the evening or the night. So this is the standard dose of hydrocortisone that you're going to prefer. Remember, fludrocortisone dose, if at all you need it, you give. Usually the dose is 0.05 to 0.1 milligram. Either you can start with OD dose or BD dose depending on the response. But remember, fludrocortisone is not needed if your hydrocort dose is more than 50 milligram per meter square per day. All these are very important data. I have made a detailed discussion already in the congenital adrenal hyperplasia section of 20-hydroxylase deficiency. So just I am recapping that for your information. And don't forget about the stress dosing as well. I have described in detail about this stress dosing already in the congenital adrenal hyperplasia section under the 20-hydroxylase deficiency heading. So I'm not going to tell this once again. But remember, stress dosing is needed only for physical stress, not needed for psychological stress. Similarly, only hydrocortisone dose should be increased and no need to increase fludrocortisone dose if at all the patient is getting. If they're not getting, fine. If they are getting, then no need to increase the fludrocortisone dose. Just increase the hydrocortisone dose. During stress, that's enough. And again, it's not needed for psychological stress. It's only needed for some physical stress like infection or diarrhea, vomiting, which I have discussed already. And similarly, surgery needs extra doses because surgery is a huge stress. It depends on whether the patient is dealing with a minor surgery, that is defined as any surgery lasting for less than 45 minutes or so, or a major surgery, which is defined as any surgery lasting for more than 45 minutes or so. For a minor surgery, just give 100 milligram of IV bolus of hydrocortisone. COTS means hydrocortisone. 100 milligram IV bolus of hydrocortisone just before the surgery. That's a very important step. Even in case of a suspect adrenal insufficiency where you want to take an emergency surgery, you don't know the status, just push in 100 milligram of hydrocortisone shot and take the patient for surgery. That will protect them against developing crisis on table. 100 milligram bolus. This will be followed by 100 milligram infusion over 24 hours. Or alternatively, you can give 50 milligram QID dose also. That's also fine. So depending on that. So usually we give 100 milligram bolus followed by 50 milligram QID in our centers. But it depends on your personal expertise. And at the same time, please do understand the fact that after minor surgery, you can, after the first 24 hours of minor surgery, you can immediately shift back to the old dose of hydrocortisone, what the patient is taking already, or if the patient is not taking the dose already and the patient is a known case of adrenal insufficiency, you can give the replacement dose as usual what you're going to give. There is no need to taper this high dose to a low dose. But in case of major surgery, the tapering is very important. Let us see. So for a major surgery, you start with a 50 milligram per meter square stat dose of hydrocortisone. This should be followed by 100 milligram per meter square per day infusion for 24 hours. That should be again followed by gradual tapering. Gradual tapering. So usually in our routine setting in adult people, what you will do is 100 milligram stat dose of hydrocortisone, that will be followed by 100 to 200 milligram dose of hydrocortisone as an infusion for 24 hours, or we'll give 50 milligram per every 6 hours for 1 day. Then followed by gradual tapering. Gradual tapering in the sense you have to give 50 milligram per meter square per day for 3 days, that is 100 milligram, 50 milligram BD or QID for 3 days, then followed by 30 milligram per meter square per day for another 3 days, then you shift to standard replacement dose. You shift to standard replacement dosing. So which means when you are doing a major surgery, the most important point is you have to taper gradually after the initial dose. That's very important. You should not suddenly stop the dose because of the high level of inflammation and injury and stress that happens during a major surgery. So it's better to taper gradually to prevent any adrenal insufficiency in that regards. So I think we have discussed in detail about the adrenal insufficiency, which is a very, very important topic. With this, I'll close down the session and we'll move on to the next session on adrenal incendilomas.